Good afternoon. I'm Giselle Corby-Smith, professor in the Department of Social Medicine and Medicine at the UNC School of Medicine. I direct the UNC Center for Health Equity Research and co-direct the Clinical Scholars National Leadership Institute. We'd like to welcome you to the second in our webinar series on communities in partnership, ensuring equity in the time of COVID. This webinar series is hosted by Community Campus Partnerships for Health and the University of North Carolina Center for Health Equity Research, and is co-sponsored by the Clinical Scholars National Leadership Institute. Before launching today's session, I want to acknowledge the overwhelming response to our first session last week. The positive responses resulted in us in this change in the webinar platform, and some of you all have experienced a little bit of the technical glitches that we're still working through. Hopefully this will, in the future weeks, will allow us to more efficiently manage the online experience and ensure that the number of people that wanted to register and participate are able to do so. Joining me today as co-moderator is my longtime colleague, Al Richmond, Executive Director of Community Campus Partnerships for Health. Today's session is another fast-moving time together. Before we start, we have a few ground rules to let you know of. Your audio and phones will remain muted for the duration of the call. However, you have two options to communicate with both the panelists and other attendees. Any questions that you have for your speaker should be placed in the Q&A box that's at the bottom of your screen. We won't be able to monitor the chat box for questions, but you can utilize that chat box to message all the attendees during the session or the panelists. This webinar is being recorded, and this and prior webinars are going to be available on both the CCPH and the CHER websites for review and for you to share with your networks. And finally, realizing that we're all managing at home or in places that may not be what we're used to, we ask you just to extend grace to anything that happens on the webinar, barking, children, people walking behind us. We're all trying to make do. So just a little bit about today's session. The term essential workers has really taken on a new and oftentimes confusing meaning during the COVID-19 pandemic, in part because each state, each region has a different definition of what jobs are deemed essential. These essential workers are often those tasked with providing important services and support for our communities. Today, we want to lift up and highlight two of those sectors, farm workers and home health workers.
So as we move forward, we want to share with you the learning objectives for our series of webinars. They include to ensure diverse perspectives on COVID-19 and its impact on health equity, to also develop a network to support systemic changes in response to COVID-19, and finally, to evaluate collaborations and partnerships in understanding equity and the response to COVID-19. Today, we're so excited to have joining us three amazing speakers. Our first speaker that I will introduce is Dr. Antonio Tovar Aguilar. Dr. Tovar is Executive Director of the Farm Workers Association of Florida, where he is actively engaged in supporting thousands of workers who help put food on America's tables. Dr. Tovar is also a member of the Board of Directors for Community Campus Partnerships for Health. Welcome, Dr. Tovar. Antonio, as I call you, the essential role of farm workers has never been more important as this nation has grappled with the shelter-in-place orders. At the same time, we've all visited grocery stores and we've seen empty shelves, and we have experienced the frustration with the ability to access fresh fruits and vegetables. Share with us today about what you are seeing on the ground and how COVID-19 is impacting your work and those that labor to feed America.
Yeah, well, thank you, Al, and thank you all for having me here today. I'm going to share my slides. I hope that you can see them. And basically, like you say, the association have seen the farm workers as essentials for their inception. The Farm Worker Association of Florida is a 37 years grassroots organization. We are a membership of an organization because like we are going to see, many of these workers are unable to be union. We are one of the limitations of the of farm workers is that they are not allowed to be to form unions. So and there's many other legal aspects of these. We think that we can trace the origins of inequality on farm workers from the process of how agriculture has developed in the United States. And I would say that is slavery one of the reasons because this inequality exists. The first picture that is in this slide is actually a Seminole, a Black Seminole, because during the colony in Florida was part of Spain, many African American that were slaves in the colonies of the British colonies, they or even during the independence of the United States, were moved to Florida and they were free once they crossed the border. And there is a substantial history of the Black Seminoles in Florida. But farm workers in general were excluded from the most of the regulations that provide for minimal working hours, overtime, social security. Farm workers are unable to unionize for most of the United States. There is an exception in California where for many years, they have fought for recognitions of their rights. And in effect, last year, farm workers were paid overtime after 50 hours of work. So that's some of the exceptions. They were also able to unionize in other parts like Washington State, North Carolina, but for the most part, farm workers are not able to form unions. And that's what we call the agricultural exceptionalism. They under the pretext that farm workers are essential and national security will affect the provision of food, they are unable to receive the rights. And until this 80s is when there's some movement to create some protection. They are also excluded from the Occupational Safety and Health Act. So there was no supervision in terms of their health and safety. Now, the association has always think that it's important to research farm workers because very early on, when we were doing advocacy for farm workers, we always hear from policymakers that where is the data that the recount of farm workers themselves was not going to be important. So we start very early on to do community-based participatory research with academic institutions, mainly from Florida, to start to document exposure to pesticides, to also look into heat stress, and other kind of injuries, so we can tell the legislators that this was happening. Now, the data that I'm showing here is the national data from the National Agricultural Research that it happens every 5 years. So these are more global data. It is a little bit different in Florida because something that happens in Florida is that there is a lot of seasonal workers. Now, there is these two distinctions between migratory and seasonal farm workers. Migratory is the ones that are following the crop, and seasonal are the ones that stay in the same location and they harvest depending of the season. And we have most of those workers in Florida. So let's jump into on how COVID-19 has affected farm workers. One of the main productions in Florida is ornamental crops. So ornamental crops is those flowers and ferns and all those products that they pretty much were unsold because they were not market for them, and they have been closed for the last between 4 and 6 weeks that they are no production. Now, there's a lot of crops that they were mainly for restaurants, like the tomato industry, and that market collapsed too. Many farms, they redistribute part of their crop to food banks, but they couldn't take all the tomatoes. So there's a lot of, not just tomato, but other crops like cabbage, and all these crops, they're pretty much destroyed because they couldn't find a market. There is some other crops that is still harvesting, and obviously the workers over there risking their health to do these crops. So obviously, most of these workers that lost their job do not qualify for unemployment. Even mixed families were excluded from the CARES Act. There is very limited testing in Florida. Just a couple of days, we get to 1% of the population. So Florida has over 22 million people in the state, but only over 200 tests has been done in the state. And obviously, farm workers do not have PPE. There is research opportunities after this pandemic, and there is also some efforts that we have done to cover some of the issues that we mentioned. So food system is something that we think is very important to do research and also to document. The association always have promote food sovereignty as a way to be a more equal society, but I think that we need documentations in terms of food system and how this works. Obviously, there's going to be effects on mental health and the relation with PPE and testing. It is important to do research about social support and social capital, and also to look into the migration paradox, which is this theory that look into how migration moves to the United States, and they are actually better off with less resources than the local population. Although we also see epidemiologic transition in many of the workers that have been here for a long period of time. The efforts the association has done is a lot of education, a lot of very short videos in different languages, building masks for workers, do a lot of support as well, this redistribution of food, and a lot of advocacy, because obviously these workers are unprotected. And I'm going to end there because I know that there's more to share with the other panelists, so thank you.
Thank you, Antonio. I have several questions for you that have been generated. First of all, your comments regarding the migratory patterns, are you seeing some changes? Are people leaving Florida or maybe even other areas where there's been a collapse of the work in those communities?
So, for instance, it's going to change from crop to crop. Blueberries, for instance, is one of those crops that most of it is going to the supermarket. So it's being harvesting, and blueberries are going from south to north. So right now, many farm workers, they are moving to Georgia, North Carolina, where there is blueberries. The tomato, it's gone. Like pretty much most of the tomato, 80% of the tomato that it's harvesting in Florida, Tennessee, even Colorado, is going to the restaurants. So if you go to the supermarket, most of the tomatoes you are going to see in the supermarkets, they are going to have the label from Mexico, Canada. There's some local tomatoes, but it's going to be a very small margin. So Now, many of the tomatoes is harvested by guest workers, so H-2A visa workers. They are being sending back to Mexico, or they are actually switching jobs, which is very uncommon. One of our criticism of the program is that they need to stay with the same worker for all the season, and they couldn't change jobs. But now the government allow for those switch of jobs. So some tomato pickers are moving to blueberries, for instance. But it's going to be changing depending of the crop. There is some other crops that are still ongoing, like for instance, eggplants or sweet corn that it's still ongoing in Florida, and it will move a little bit to Georgia. We saw in Georgia that the most of the crops in there are not for restaurants, but for the supermarkets. So there's a lot of workers in there.
Yeah. So our a question has come in, and that question is, are workers still working based on piece rates? And how does this payment scheme impact COVID-19 precautions, which are slow for workers in this field?
I'm thank you for that question, because that's one of our main criticism of farm worker in general, food system. Most farm workers are paying piece rate. So a bucket of tomatoes is 80 cents for the big tomato. Obviously, when you go to the supermarket, the price is completely different, right? Oranges, a bag of 90 pounds oranges, it is $180 for a bag of oranges. So piece rate is terrible because it increased the occupational risk of workers. They have to go very fast. Most of our more recent research is about heat stress, and we have seen that more than the climate, working very fast have more effects on the symptoms of heat stress and kidney damage. So piece rate is a risk factor that it's very, very bad for workers' health.
Antonio, you mentioned earlier a number about the number of COVID-19 tests that had been done in Florida. Could you repeat that number? And also, has there been any testing among farm workers?
Yes, so there is, what I was saying is Florida has 22.7 million inhabitants. And yesterday, the amount that I saw, it was 285,000 tests in the whole state of Florida. So it's just a little bit over 1%, like 1.2% of the population. There is one clinic, many rural clinics actually closed, but there is one clinic in Homestead that opened and start offering testing. So there's some farm workers that are start to be testing. We are going to actually also have a testing day in 1 week in our office too. We are just going to, we just get offered 100 tests. So we are going to have 100 people that is going to be tested for COVID-19. But the percentage is very small. The health department, the Florida Health Department and the hospitals are telling people only to come to the hospitals when they are very sick, and then they are going to be tested. So that's why also the percentage of tests are coming positive because there's just few tests. So like 40% of the tests that are conducted are coming positive because most of the people is going there when they have a lot of the symptoms.
Antonio, is this a point of organizing among farm workers? And what can we do as academics and community partners to align ourselves as allies with this work?
So something that we have done, and we are very thankful with many of our partners in the academia, is that when we do research, it is time to do advocacy for farm workers. They actually come and testify in the local Congress, and even sometimes has happened at the federal level. I think that it is very easy right now to document that farm workers are not receiving PPE, that farm workers are not being tested, and then we can see the consequences. That's what I was talking about. What are the opportunities on doing research, and what is the consequence in terms of what to do for changing the system. So the peace rate, for instance, is a great example. There is already a body of literature that document how peace rate endangered farm workers, and even the APHA. I collaborate on having a policy statement from for APHA in terms of food workers and how the peace rate is affecting farm workers the most.
Mhm. One final question before we move to the next presentation, but did you hear any impacts of the government's recent public charge rule on migrant workers and their willingness to seek care and testing for COVID-19?
Yeah, there is a lot of disinformation on the public chart because, and we saw immediate impact on that because what it happens is that most families thought that they were going to be directly affected, so they stopped going to receive food stamps for their children, or they stop getting the Medicaid for their parents if they were undocumented. So there is a lot of mixed families in all the United States. So it was hard for many of these workers to understand that if the children was receiving food stamp, it's not going to change their situation because they will not qualify anyways, and it's not going to affect it. The actual impact of the change of policies of public health is in public charge is going to affect a very small percentage in Florida, that they are the ones that are moving from the blue card into citizenship. And unfortunately for farm workers, that's a very, very small percentage.
Antonio, one final question, one more quickly, 30 seconds. You talked a lot about farm workers, but we're hearing a lot about those who are working in the poultry industry. Has any of your work extended to that? And can you give us a real quick snapshot of that?
Yeah, we don't have a lot of packing houses in here on meat, but we have a mushroom pack house that is huge in the area. They have like over 500 workers. They work 24 hours a day. There's 3 8-hour turns. They are actually paid by hour. They are not paid by piece. But the company said that it's providing PPE, and we know for the workers that there is no PPE. So we are actually providing PPE to the workers so they are safe. But we have the same problem. There's no testing. So hopefully some of those mushroom packing housing workers will come to this testing day, and we can to start to do some assessments on that regard.
Thank you so much, Antonio, for joining us today.
No, thank you.
Our next presenters are collaborators in their research. Dr. Madeline Sterling is an assistant professor of medicine at Weill Cornell Medicine and New York Presbyterian Hospital. She's a practicing general internist with formal training in clinical epidemiology and health services research. Her specific research investigates social support in heart failure and the role of paid home care workers or home health aides or personal care aides in chronic disease management and patient outcomes. She partners with 1199 SEIU Home Care Industry Education Fund and several other licensed home care agencies in New York City. Ms. Faith Wiggins is one of her partners and oversees the grant and collective bargaining training program, the Basil Patterson Scholarship Program, the Citizenship Program, and the English as a Second Language Program at 1199 SEIU Home Care Industry Education Fund. Maddie and Faith, global attention has focused on New York as we've watched sometimes with horror the devastating impact of COVID. Please share with us. We're very excited to hear about your partnership and how your work has been impacted by COVID.
Sure, and thank you so much for having us. I'm going to share my screen. Okay, so today we're going to talk about home care workers who are frontline caregivers. Sorry, let me just go back. Home health care workers and COVID and sort of the experiences from the front lines. And what we're going to do in this short amount of time we have together is give you a bit of background on who home health care workers are and some of the vulnerabilities that this population of caregivers have at baseline. And then I'm going to ask Faith, who directs the Home Care Industry Education Fund, to talk about efforts that her organization is currently doing in the face of COVID. And then finally, we'll present some real live data from the front lines about the actual experiences of workers here in New York City and sort of the reaction to those experiences. Just a disclosure, I'm funded by NHLBI and the Robert Wood Johnson Foundation to conduct research on home health care workers. So who are home health care workers? Actually, they are one of the fastest growing sectors of the healthcare industry and US economy. I'm sure for those of you who are doctors, many of your patients might have them. For those of you who have older relatives, you may have them too, or you may have had one yourself. There's actually nearly 2.3 million of them, and the demand for them is skyrocketing. You can see that there'll be projected 4.2 million demand by 2026. Home healthcare workers are trained and certified health professionals. This is really important. They have a scope of care and require certified training. They provide daily or near daily support, personal, emotional, and medically oriented care for patients in the home. And as you may know, there are many different types: home health aides, attendants, personal care aides. This is sort of beyond the scope of this talk, but just to say that they actually all perform these functions which are critical for patient care. And really, they're known as the eyes and ears in the home. So patients might have family members helping, but many, for example, in New York and around the country, also have paid home care workers. I'd like to point out that this is a vulnerable population even before COVID. Home care workers are majority women, minorities, foreign-born, and at least have some college, but typically high school education. And as many of you might know, they make a local minimum wage. So here in New York City, that's a bit higher than elsewhere, but typically these are considered low-wage frontline workers. And I think what's come about in the last several decades is really a story of this workforce providing integral care, but consistently being overlooked and undervalued by the medical society and society at large. So sort of being this invisible population of direct care workers. As a researcher, in order to understand the challenges that this workforce faces and to understand how they impact care, I've been partnering with the Home Care Industry Education Fund of 1199 for the last 4 years. I'm now going to ask Faith Wiggins, who directs this organization, to tell you a little bit about it.
Thanks so much, Maddie. Good afternoon, everyone. It's really an honor to be here. First, just to set a little bit more context for our organization and where we sit in this space. The 1199 SEIU, United Healthcare Workers East, is one of the largest labor unions in the world, with a membership of over 400,000 workers and retirees that most of which are in the healthcare professions. And the labor union is not only in New York State, but also Massachusetts, Florida, Maryland, DC, and New Jersey. So the labor union is sort of the mother of us all, and there are jointly managed funds to provide benefits for the labor workforce, which includes educational benefits. And that's the space where the 1199 SEIU Home Care Education Fund rests. We're part of a group of funds that are jointly managed by the labor union and by industry leaders in the hospital, nursing home, and home care sectors. And our work is organized around the labor force that we're providing services to. The Education Fund provides training and educational services to the 75,000 home care workers, mostly in the 5 boroughs of New York City, but also some in Long Island and also in Westchester County. And we work with 55 agencies across those regions. And our challenge really is to meet the needs of the workforce and of our employers by really staying abreast of what's happening, what are the emerging needs, and how do we make sure that the workforce, the frontline workforce, are getting the skills and training and access that's needed to provide quality care. So home care workers in this space of COVID, has really been, again, an invisible story. We're hearing a lot in the news about what's happening in hospitals and unfortunately really negative news about what's happening in nursing homes. We have not heard much in the public media around the things that are happening in the home care workforce, again, invisible. And for the nursing home workforce, unfortunately, we haven't heard the positive stories of the work that's being done by many, many people to provide care in this very, very difficult time. So what we do know is that the workforce in long-term care is really comprised of older people, many of which are a part of the essential workforce, however, have the conditions that really should require them to stay at home if possible. So what we're seeing so far is that about 15 to 20% of the home care workforce is opting to stay at home. We also have an experience in New York City where most of the home care workers that we work with are providing services to Medicaid recipients, that some of those families are refusing to allow service because they're afraid that the home care worker who has traveled often on the New York City subway system, and yes, everything you've heard is probably true, not the way that anyone would like to travel if you have access to other means. So some are refusing service because they're afraid that the worker themselves might expose their homes, their families with the COVID virus. Also, as a result of the CARES Unemployment Act, most workers, if they opt out of working or are in a protected class, are better off financially collecting unemployment because there's a supplemental benefit that goes along with the unemployment benefit, which then has that worker earn more or collect more in their unemployment package than they did as a low-wage worker. However, one of the other things that we know right now in this sector is that because of the dire need for healthcare workers, home care workers are now able to work in nursing homes and other settings based on their home care credential, where before they were required to take additional training. For example, for a home care worker who has had usually over 100 hours of training to work in a nursing home, they had to participate in a second training that again was 110 or 120 hours, even though the skills really are transferable. So now they are able to work in nursing homes and in other settings using the skills that they have, which includes taking temperature, pulse, respiration, other measurements, and providing the kind of comprehensive care that folks need in their homes.
Great. Faith, that's a wonderful overview of sort of the large picture of what's happening. I think an important thing is that while we hear from daily Governor Cuomo's updates and potentially in the lay press, sort of these large-scale changes to the home care workforce, I think little is actually known about the experiences of these frontline healthcare workers. And as a researcher, I think it's important for us to understand them in order to do both advocacy for potential needs and also interventions, including policy. So I'm going to take you through a little bit of a sneak peek at a current study we are doing here in New York City, partnering with the Education Fund and Faith's team. And our objective is to understand the experiences of home healthcare workers who are caring for patients during this pandemic. I'm sharing this data with you because I think it shows in real time some of the challenges that workers are experiencing. This was a qualitative study. We used purposeful sampling with our community partner to recruit home health aides and home care attendants who currently work for a variety of home care agencies across the 5 boroughs of New York City. These one-on-one interviews were done via telephone, obviously given COVID, and they were about 30 minutes in duration, and we analyzed the data using grounded theory. I'm going quickly just for sake of time. We included home healthcare workers who are full-time or part-time employed by a licensed or certified home care agency here in New York. These are the sort of questions we ask them because these may be the questions that you're also wondering. How has COVID affected your day-to-day work? Has your agency provided you with information or training on COVID or equipment? Have you cared for a client with COVID or suspected COVID? Have you yourself had symptoms concerning for COVID? And what worries you the most? We felt that these questions would be able to really get at the heart of the issues. So I'm going to go through the results. First, I'll show you the participants, then the main themes that are emerging, and then finally some real quotations from participants so you can actually hear what they had to say. So far to date, we've interviewed 23 home care workers. As you can see, like Faith alluded to, this is an older population of workers, a mean age of 48. Not surprisingly, the majority are women and most were Black and Hispanic. In terms of experience, you can see that actually home care workers in our sample are quite experienced with 11 years of caregiving experience, and our sample pulled from 18 unique agencies. Again, a real nod to our community partner, which really has a wonderful reach that allows us to sample from such a breadth of agencies. This is a map of New York City. As you can see, our participants are hailing from all 5 boroughs. The stars are the agencies where they currently work. And these are the themes that emerged. I'm going to go through them each with quotes in a minute. So first, communication and workflow regarding COVID from home care agencies is really variable. Workers are currently hearing different things about the disease and different precautions. While some home care workers have received personal protective equipment, others have had to purchase it for themselves. And as you can imagine, that is challenging given their low wages. Home care workers are currently balancing the duty and the calling for the job that they feel, but also against the risks of transmitting it to either themselves and their own family members. We're finding that home care workers are highly anxious about public transportation, especially here in New York, as this increases risk of transmission. Despite fears of COVID, and as you might expect, home care workers cannot financially afford to stop working, and so they continue to do so. And finally, we're seeing, unlike, similar to before COVID, home care workers feel that while they're integral to care, they're not really seen or appreciated by the medical community or society at large. We'll just quickly walk through these 6 themes, and I think that'll give you the real flavor. So communication and workflow about COVID is changing and variable. So no one ever called us to tell us what precautions to take. That's one participant. While another one says, what happens if my client gets sick? There are 5 of us aides that work with her. So typically, it's not just one aide per one patient, it's often many aides at a time. This is about personal protective equipment. One aide says, I'm wearing a mask 24/7, but I don't know how long that's going to last. There's a limited amount you can get from your job. So sort of this fear of running out of equipment. Another aide says, I'm taking money out of my own pocket to buy my hand sanitizer and face masks because I don't want to get sick and I don't want my clients to get sick. This is about balancing risk. One aide says, "It's like walking right into the fire. Am I going to come out alive?" So you really hear the fear there. Another aide is worried about transmission to family. "I'm living with my daughter and she has young children. If I get affected, I could infect my daughter's family." This is about travel. One aide in New York City says, "I take 3 buses to get to work, the number 9, the 19, and the 5 bus. That's a lot of traveling and being around a lot of different people." This aide actually then went on to tell us that she actually decided not to work, as Faith had said, as a trend, because she just was too fearful of the subway and the bus. "If I don't work, I can't pay my bills. It's that simple." So here you see that financially, it's very hard for workers to not work despite risks. And finally, we hear a lot of this: "We are heroes too, but we are never on the news." It's not a job where you can work from home. You really just have to be there. So these were the 6 themes. In response to these themes, I'm going to hand it over to Faith, who's going to tell you a little bit about what her organization is doing to try and work on these issues in real time.
Thanks, Maddie. So we've done quite a few things, and I think we have some slides that give images of some of these things, but just to give a quick overview, our employment center has opened a application portal where we have healthcare workers and others who are willing to work with COVID patients registering, and we're matching those applicants with employers. We've also created a video for workers that's available in 6 languages. And fortunately, with some funding, in exchange for watching the video, we'll be able to provide some workers with a cash stipend in the form of a prepaid debit card that can help with mitigating some of the expenses related to providing care. We've also developed some online courses on confection control and stress management to help workers in this time. And in our other broader educational programs, we've also transferred a lot of our chalk and talk in the room classrooms to online learning, and also teacher-led content, but with participants using Zoom or other means to engage with their classmates and teachers, and an online English for speakers of other language program that is built around home care specific content. We have safety tools and checklists for home care workers, and we're partnering across New York State and in some other areas to identify sources of personal protective equipment for the workforce. We know that's one of the really important areas of need, and it also defines whether or not it's safe for a worker to work. And lastly, while our education fund's initial and founding purpose was to provide education services, our trustees met 2 weeks ago and expanded our purpose to include providing access to resources during times of public health crises, such as the one that we're in. So we're now able to use our 501c3 to actively fundraise for help for the home care workforce for COVID-related expenses. So here are some examples of some of the things that we've done, and I'm sure that we can share our website where this COVID-19 video for healthcare workers is up. Also the infection prevention course, which is really focused on workers who are providing environmental services or cleaning in hospitals and nursing homes to make sure that they're providing those services in the most effective and safe way. Also, we've created this household action plan that's a double-faced document that we are sending out in a text blast to home care workers, so they have a real tool for what is it they should be doing for their safety and their patients' safety during this time of COVID. And it's structured in such a way that they could have it on their phone and save it as a document. And for everyone, we actually have a webinar that we're hosting on Sunday, May 3rd, that's titled COVID-19 Resilience and Wellbeing. For our $11.99 union membership, attending this course is free of charge. For others, there is a nominal fee to participate. And of course, resilience, self-care, these are all things that we have to do in these times.
I think, Faith, it's amazing what the organization has been able to do in such a short time. At the national level and in New York State, other efforts for home care workers include sort of advocacy and action around credible and clear information about COVID. As you hear, a lot of home care workers just aren't, if they're not lucky enough to be part of a union or organization fund like this, they might not be getting those expert sort of trainings. Also essential worker designation. So in New York State, home care workers are considered essential workers, but this might not be the case in other states. PPE has been a huge issue in sort of raising funds and advocacy efforts around making sure that not just the doctors and nurses are getting PPE, but also workers. Paid sick leave is a huge issue. There was a bill passed in Congress with Representative Nina Lowey leading it a few weeks ago about paid sick leave for workers who are affected by coronavirus, but unfortunately this leaves out of millions of home care workers who might not be part of small businesses, but may be part of large organizations. And again, if without union coverage, may leave many of them vulnerable to not getting any wages. And then finally, just awareness and support. I think just getting the word out that these are integral members of the healthcare team and really needed to be treated like that. And also the claps that are going on around the country at 7 p.m. I think we ought to start including home care workers in that sort of first responder line, because as you can see, they're really providing a lot of hands-on care in the home. I'm going to stop there and take questions. I will both take questions. Thank you so much.
Thank you, Maddie and Faith. That was a fabulous presentation and really highlighted the vulnerability as well as the essential nature of the work that home health workers provide. So we have a few questions. I'm going to toggle between questions that are in the Q&A box and questions that we got ahead of time. One is that there's a tension, and you all alluded to this, between the economic stability of home health care workers and reducing the risk of this vulnerable population to COVID-19, given the need for the work. Could you comment on viable solutions to address this tension?
Maddie, I'll start. You can jump in. Well, the strategy really is around financing in home care and in the space of the New York City workforce. You know, these are positions that are funded with Medicaid dollars. Those dollars are flowing through managed care organizations that then contract for the service with home care employers. And unfortunately, the margins are very, very small. So, for example, an employer that I spoke with yesterday spoke about the cost now to their business of purchasing PPE that before was not necessary, in addition to the other pressures of if there's not a worker going to work, then you're not earning. So really the solution is for more money to flow to the caregivers by having higher rates of pay through the reimbursement system that's in place now, or the payment systems that are really controlled by the Medicaid dollars. And Medicaid across the country is being cut. So really it requires a comprehensive government response to move money through and then directly into the hands of the workforce.
Thank you. Thank you for that. Another question is, has there been any impact of the rapid COVID-related adoption of telehealth and telecommunication tools to enhance patient family education in both the inpatient and outpatient setting to improve the experiences of home healthcare workers? And have home healthcare workers and agencies benefited from closer coordination and communication with physicians, hospitals, and clinics?
I can jump in. I think that's a fantastic question because for those of you who are in medicine like I am, our practice changed overnight from seeing patients in person to virtual visits for outpatient care. Faith has done a lot of work with technology in the home care space, and I personally work with our Cornell Tech campus to try and design technology for home health aides. I will say from the agencies I've spoken with, the response yet so far has not been coordinated. I think there have been hotlines and telemedicine established for workers so that they can access medical doctors for themselves. But in terms of caring for, if they had symptoms, but in terms of caring for their patients, I would say there is some innovation happening at the agency by agency level, but there hasn't been a large scale coordinated response of telemedicine or home care delivery as far as I know of in New York City.
I didn't know if Faith wanted to comment on that or.
No, I think Mehdi covered it.
Okay, great. Another question is, do home healthcare workers have access to COVID-19 testing? Do they perform or collect the tests, or are they themselves tested?
That's a really great question. So as Maddie indicated, the union workforce is in a very different position than many of the home care workers across the country in that they have a comprehensive health plan that includes teledoc and other services. And yes, if a home care worker is exhibiting symptoms, then they would certainly be a part of the essential workforce that can get access to a COVID test ahead of the public. New York City recently implemented a program where all essential workers are going to begin being tested, and we're going to make sure, my union leadership is going to make sure that home care workers are included in that testing, early testing option.
I think yeah, exactly. And I think the counterpart to that is that the home care landscape is complicated. We didn't at all today delve into home care workers who are not working through licensed or certified home care agencies, and those of whom are hired by family members. So in New York City, that's called the CDPAT program, Consumer Directed Personal Care Assistance. And so those workers, it's really actually, and then of course there's workers that provide services not part of any agency or organization. So I think we have a sense that for those who are under licensed agencies or union coverage, especially in New York, they have access to testing, but there's a whole sector of the market that we didn't discuss today that actually may be vulnerable and not able to get tested, or maybe transmitting the virus on to their clients, unfortunately.
And then another question is, there's the dilemma for workers and families with senior loved ones. Seniors continue to need services more than ever, while families who live in another household or unable to provide all of the loved one needs. How do you assess and rebalance who gets the required services?
That's a really interesting question. So again, in our case, the services are initiated when there's a patient, older or otherwise, that is in need of care at home to help with their activities of daily living, or who recently had surgery or some other event that required follow-up that could not be accessed by going into a center or into a doctor's office. So home care services are initiated that way. So the impact in terms of older family members and providing care, I think, it's more complicated with COVID, especially in a city like New York, where most people don't have the room to spread out. So you have multiple generations all in one apartment. So when there's someone receiving care, it impacts everyone in the home. And there are certainly families that can't access the services of a home care worker, a home health aide, at least not immediately, and more so in this time of COVID.
I'll also add that just like in the hospital where we've been in New York City, you know, our hospitals are completely transformed, and it's been very challenging to actually discharge COVID positive patients to rehab facilities as we might normally. You could actually imagine that if a patient tests positive for COVID, there is also some resistance and challenge to get them new home care in the home, because you're not just that, or that requires an in-person assessment, personal protective equipment. You need an aide that's willing to do the case. You need a family member that's okay with the risk of the aide coming, who may or may not, you know, be an asymptomatic carrier. So there's all these nuanced risks that I don't think previously existed. And then, as Faith said, layer that in with multi-generational small apartments in New York City. And really, I think, you know, it's fitting that we're speaking at a health equity seminar, because I think you could just see all of the players that are really funneling into how challenging this is going to be in the next several months.
I'm going to ask one last question to each of our panelists, and we'll ask you all to answer very briefly, and in turn, we only have about 1 minute left, but there was, the questions that came in earlier, there was a general theme of what can we do as citizens to advocate for economic inclusion? COVID-19 has exposed both the disproportionate number of vulnerable populations and the lives lost due to COVID. And we also have this paradigm where essential workers and first responders' salaries don't correspond to the extreme value that they bring to our societies. Can you all just briefly, each of you, talk about what you see citizens, what you'd like to, the message you'd like to give to folks on this webinar about what they can do to advocate for equity in this space?
So something very concrete and quick is that many farm workers do not qualify for the incentives that were put together the first time. So, and they pay taxes. Many of them pay taxes or have mixed families. So I think that if any new package come, they should be included because it's just one little piece of equality for these workers.
Thank you so much, Antonio. Faith, your Twitter version of what we as citizens can do to advocate for equity in this space.
Use your vote wisely, lobby with your elected officials, and as Antonio said, broaden the definition of essential workers and have a benefit that is level to what they deserve. Raise the floor.
Great, thank you. And Maddie?
Yeah, as a physician, I would just like to sort of say that now more than ever, I think this group of workers shouldn't be invisible. And I think we really need to think about who is in the care team and advocate for all of us. So it shouldn't just be doctors and nurses that are getting equipment and sort of the support, but also those who are doing the extension care in the home, because I think they're providing a really pivotal role.
Thank you so much, Maddie. I'm going to turn it over to Al to close us out.
Thank you to our panelists and to all of you who've joined us today. This has been an amazing conversation, and we appreciate you continuing to join and support us. We want you to check out our discussion board on CCPH's website to continue the conversation. We're building energy and building fire, and we want to continue this conversation. We certainly want to invite you to next week's webinar on April 29th at 1 p.m. We'll be doing this for at least the next 2 to 3 months. We certainly appreciate any feedback and suggestions that you have for future speakers. We remind you that we have an evaluation. Please take the time to fill that evaluation out. You can use this scan code to access that, or you can also go to this particular website as well that you see on the website. We certainly want you to continue to connect to our Facebook page, but also through hashtag equity in COVID. So again, thank you for joining us today, and we look forward to seeing you next week. Thank you.